All right, welcome back to the Recovery Tapes for episode number 32. My name's Gary and I'm your host. And today's guest is a doctor and the host of the Substance Stories podcast. So I've been really looking forward to talking to you, mate. Can you please introduce yourself to the listeners?
Hey, thanks so much for having me on, Gary. My name's Rich Bradlow. I'm an addiction psychiatrist. I work in Melbourne. It's a sort of dual diagnosis, drug and alcohol and mental illness service.
So I saw your clip on your page where you went on Sunrise, man. That must have been pretty
Yeah,
cool to be on.
it was my brush with fame. Very exciting.
So you mentioned some pretty high statistics and stuff like that. So I did want to get into a bit of that chat later on in the
Yeah.
podcast. But before we start and get into it, could you please tell us a little bit about your background and how you actually got into this type of work?
Yeah. Okay. Yeah. No worries. So I am a psychiatrist. So I did med school, in med school, I actually became pretty disillusioned with med school. I sort of stopped doing it for a bit and tried to become a model/actor, but realized I didn't quite have the looks. So we went back to med school, finished up, and then when I did my first psychiatry rotation, um, I just loved it. Thought this is what I'm all about. I remember that people were interested in helping this sort of holistically seeing patients as people rather than as a single organ. And we were spending lots of time talking to one person rather than seeing 30 people in an hour. And the people that I was working with were really interested in the health of their colleagues and their patients. And I just fell in love with it. And then when I was doing my first year as a doctor, as an intern out in Gippsland, I realized that it was that sort of same thing that was drawing me into. I remember doing a ward rounds when I was a med student, and there was someone that was clearly in a lot of emotional distress, but the gastroenterologist didn't give a shit. They were just trying to get the liver all right. And I was sort of thinking, are we going to help this person? And then when I was doing the psych rotation as a junior doctor, it was the same stuff for addiction stuff. There was someone that were very focused on but very siloed into the mental health side of things. And I was like, we're going to talk about this person's addiction. This to me feels inextricably linked. So then I did a master's in addiction, did my training in Canberra and New South Wales, and then back to Melbourne. Just moving around a lot for my wife's work. Then I finished my training a couple of years ago, and I've been doing a PhD and teaching in Monash in the sort of psychopharmacology and ethics and addiction stuff there. And what else do I do with my life? And then, of course, I started this, and then I had this opportunity to start a ward, like a program all to myself, which was really exciting. So I got to design with a guy I trained under. We got to design a program at the Victoria Clinic in Melbourne, which is from the ground up. We designed what the classes are about, because I guess one of the things we felt about addiction is that it can be too clinical and it can be too medicalized. And we're really passionate about sort of that holistic stuff. So we have a big focus on, the connection to spirituality, connection to exercise, meditation, getting your diet right, focusing on things that I think a lot of doctors would view as not medical, but we would view as really evidence-based and path to sobriety and happiness. And I guess we have a different view. Well, I think it's a very commonly held view, but a different view to many programs where we really think that it's not really about the addiction as much as it's about what is causing the addiction. And I think that a lot of sort of programs can focus too much on you just need to get abstinent and then your life will be magically better. Or we're sort of like, well, actually, your addiction is happening for a reason. And often people feel a lot worse when they get abstinent for the first time, because all that things that we've been using our addiction to cope with are right in our face. So what I say, the goal is not abstinence. The goal is a content life, but abstinence is an absolutely necessary step on the way to a content life. I think that the AA phrase is the best thing about sobriety is getting your feelings back, and the worst thing about sobriety is getting your feelings back. So that's sort of what I'm up to in a nutshell.
So you've been a very busy man then. So when you mentioned the sort of the degree that you did in addiction, what does that sort of entail, man?
Yeah, so it's pretty clinical. So you obviously, to be a psychiatrist, you get a med degree, and then I did a master's in addiction. It was run by this cool program, University of Adelaide, this university in America called Virginia Commonwealth University, and then a university in England called King's College London. So they sort of shared it. So it was all online. It was very, very. It was a big mix. And so it covered. It was obviously postgraduate, so it covered a lot of the sort of really nitty-gritty psychopharmacology, how do drugs work exactly. It also covered a lot of the sort of theoretical, what is addiction, why is it happening, from a sort of psychological, but also a really social aspect, and had, really interesting, probably the most interesting subject in there was one on the history of the drug war, which was really, really fascinating. I don't know if you've ever read Chasing the Scream by Johann Hari, it does a good sort of story about how the drug war sort of came about. And it was sort of a more in-depth version of that. And then it ended with a year of a research project, which I did on differences in intravenous drug use between men and women in Australia, which was a really interesting sort of dichotomy, because there's a lot of sort of inherent biases in our services, in terms of there's very few that have sort of ability for mother baby. So if you're a woman in addiction with children, how do you enter a 8-month rehab if who's going to look after your children for 8 months? So it was really, really interesting. And then obviously there are these barriers. People are worried about going and seeking help if there are all these rules about mandatory notifications. So it's, the system is disincentivizing people to seek help, which is obviously not in the interest of their children in the long run. So that was really interesting. But then I guess on the addiction, then separate to that, you do psychiatry training, which took about 5 years. And my last 2 years of that were my addiction advanced training. So in that, there's sort of examinations, and it's all embedded in an addiction clinic in Melbourne, in Richmond, which was really cool as well. So there's a lot of different pieces to the pie. But I think you're always learning. I think the thing is, you never stop.
Yeah, man. I mean, being an ex-intravenous drug user myself, it's definitely something that I saw in our peer friend group. Some of the girls having different struggles to the boys having different struggles. And also, as well, weirdly, it was sort of like more accepted for a guy to be messed up on the drugs. And people were a lot harder on the girls as well. Like they were supposed to keep her, I don't know how you'd say it, sort of like, yeah, just be more professional or proper, so to speak. Whereas if a guy was really off the rails, people would just be like, oh, he's on a bad path, But I did see some friends of mine that were girls from back in the day that did go off the rails. They got a lot of harsh judgment from the families and the fathers and their brothers and sisters and that. Whereas, yeah, some of the guys were just sort of getting let skate a little bit.
Absolutely. That's, there's the role of gender norms that are playing a role in how people expect people to behave, and then that affects treatment. There's also the role of, there's a biological role. There are differences. So men are more likely to engage in risk-taking behavior. I mean, that's probably gender norm, but there's also men are probably just more more impulsive by nature. Women are, but there's a concept called telescoping, which refers to the time first use to compulsive use or dependent use, and women telescope much faster than men. So that's probably because of, there's this concept called the gender minority stress, where it's essentially women are exposed to much more trauma. And if you're exposed to much more trauma, you've got a lot more, a lot higher likelihood of developing an addiction. So there's probably a role of that, but there's also probably a biological role. So it's this constant complex intersection between the biological and the social. But I think that thing about men not wanting, I know plenty of fathers that have been very, very hesitant to seek help because they're worried about mandatory notification and losing access to their children, which is, as I said, it's really, really tricky, because obviously we want to protect the safety of children, but then, what is in the long-term best interest of children often is having access to their parents and parents who love them, right? So it's so tricky.
Yeah, 100%, man. So from your experience with all this, what do you reckon is a big like something that the public sort of misunderstand about all this, man?
I think that the biggest thing for me, Gary, is that even though I think I think we're better than we were in terms of stigma towards people that use drugs, I think there's still so much. And I think that people will say to me stuff like, they're not trying, or, it's about willpower. It's absolutely not. It's about, a way I talked about it is addiction is a disease that affects the part of our brain that makes decisions about substance use, in the same way that diabetes is a disease that affects the pancreas. So you can't just tell someone with diabetes to get better at processing sugar. So it's never about willpower. It's about designing a life that is conducive to abstinence, right? And that's, I think we can communicate that without saying it's also completely it's not someone's fault that they have addiction, but it's completely their responsibility to get better. So when I say, oh, it's a disease that affects decisions about, so I'm not saying that someone that's suffering from addiction doesn't have a role in getting better, but we just need to completely separate the two. And I spend a lot of time with my family, doing family work, and we're saying to families, like, we need to be understanding that relapses happen and they're part of the journey. And it's not about having a relapse, about how we respond to it. And I'm really passionate about, often families will say stuff like, if you use again, I'm going to kick you out of the house. And I'm always saying, all you are saying to that person is, don't tell me if you relapse. Because if you say to me, oh, if you do this thing, I'm going to make you homeless. All I'm hearing is, we'll never tell that person if I do that thing. And that's the opposite of what we want, because we know relapse are part of the journey, right? And we know the earlier we can intervene and learn from them, the better they'll be. And we know that, if we learn from each relapse, they're going to get fewer and fewer. So it's about having this sort of understanding view that it's a chronic condition, and recovery is a lifelong journey, and trying to be understanding and loving. I'm always saying to people, we're trying to pull people towards sobriety with love rather than push them away from addiction with hate. Because I think if we're making someone's life worse, we're actually encouraging that addiction, because there's more negative feelings to try and numb. Right? But if I'm having positive family experiences and positive sober experiences with my family, that's making my life more enjoyable. That is the end goal. So just trying to have that attitude of that it's about love and it's about connection, and it's a lifelong journey rather than this sort of stigmatized view that we are. Well, I think that it's the problem with modern medicine, right? We're used to people, you go to hospital, you get better. If I get pneumonia, I go to hospital, you fill me with antibiotics, I leave hospital, I'm good. But that's not how mental illness works. It's this long recovery journey. So we can't just, but I think the families still have that in their mind that, they've said to me they've got an addiction, they want to get better. That should be it. I'm just trying to work about expectations.
It was a really good answer, man. That was really insightful for people to hear, especially coming from the perspective of yourself as a doctor. So you touched on the back of my next question, and I'll just ask it anyway, because I've heard it a few times in a few different podcasts and sort of people on social media putting this out there. There's a bit of a question around whether addiction is a disease or not. So what's your opinion on all this, man?
Yeah. So I think, thanks, Gary. So thanks for complimenting my answer, mate. It's nice. Yeah. So look, I think I can have it both ways. So I think where this argument came about was, if we go back 150 years ago, it's the addiction is a moral failing, right? And then you go back, maybe mid 20th century, addiction is a disease. And perhaps what people are responding to with this argument about, I think people say, oh, whether it's a disease or not, I think what people are actually arguing about is, where does personal responsibility lie? Right. And I think my answer to that would be, it's both. So there's this great phrase in psychology about our feelings, which is about your emotions aren't your fault, but they are your responsibility because only you can alter them. Right. Is this great psychological phrase. And I think it absolutely applies that sort of attitude of, addiction is quite clearly a disease, but also it doesn't mean that anyone else can help you people can help you get better. It doesn't mean that anyone else is responsible for you getting better from a disease. That is, so there's this sociological concept called the sick role, right? Which is, it's come up with by this guy long dead called Parsons. He said sort of like, when we get ill, but then we also take on a sociological role, the sick role. And in it, we have two rights and two responsibilities, right? So we have, our rights are that we don't have to go to work or study or whatever that, and it's not our fault we're sick. And our responsibility is that we have to listen to the expert advice, and we have to try and get better. And I talk about that a lot with families and with my patients, is that, so it's absolutely not our fault for having an addiction. We have an addiction, that is under the sick role. That's one of the rights we have, but it's absolutely our responsibility to be trying to get better. So, and that to me fits in perfectly with the disease model. So it's both a disease and I guess the one thing is, I say I'm big on that it is a response to things, right? So it's both a disease, but it is a response to things. I often call it a sort of a maladaptive response or an unhealthy response to things, but that can be a disease.
That's a great answer for people that are listening that are struggling with addiction as well, especially with my podcast being based around, addiction recovery, and then the other side of recovering from just everything in general in life. I think you can apply what you just said to quite a lot of aspects of life and sort of incorporate that in as well.
Big time, Gary. I don't really separate it. To me, addiction is another mental illness. Like, and I think a lot of this stuff is true for all mental illness. We get mental illnesses throughout our life. Everyone does. And it's our response, it's not our fault that we get them. It's a result of circumstances, whether that's whether that's in the system we live in, or the situation we're in, or our childhood and our upbringing, or our genes. But it is,
Yeah. Yep.
it's our responsibility to get better. No one can recover for us. They can help us and they can show us the path, but it's always our responsibility.
Yeah, nice. Definitely. I definitely agree with that as well. It's definitely down to yourself to do that internal work to make the change for yourself, take on all the help that you can get from the outside sources, but you definitely can't rely on these outside sources to change your life in total way. What can you tell us about what happens in the brain when someone becomes addicted?
Yeah. There's this, so look, I always preference all this with, who knows, but there are some great theories, but
Yeah,
obviously
right.
it's the brain's the most complicated thing on the planet, in the universe, maybe, so there's this guy called George Koob, Koob, who's this American addiction researcher who writes these incredible academic articles where he breaks down what the brain changes are in the brain as we get deeper and deeper into addiction. And I really recommend, he writes in a really understandable way, so I really recommend having a read of some of his articles. But essentially what his feeling is he says that addiction is when we stop doing something to have a good time and we start doing something to not have a bad time. So that's how to communicate it, like in normal speak. In a sort of more psychological speak, you would say that's going from positive reinforcement to negative reinforcement. And in neurological speak, you'd say from impulsivity to compulsivity. But it's all the same thing. It's stop doing something so it's an action that we're doing to have a good time. So like if I'm walking down the street and I see a nice shirt, I buy myself a shirt, and I think I get a little like impulsive, like I don't really think it through, but I get a little bit of joy from impulsively buying something. Now that same circumstance, if I'm walking down the street and I'm in a terrible mood, and I buy myself a shirt to try and chase that little bit of happiness. People often will say that, like a little dopamine chasing or something. That is a compulsive action, right? I'm doing it to try and relieve stress. So what happens over time in the brain is that the dopaminergic reward system, which is really about teaching us things, right? It's about reward learning. It's at the start of an addiction really, really active. So you do something and it will fire up. But then as you go into your addiction, it's less and less interested because it's about learning. And if I've had a million beers, the millionth beer, there is nothing new to learn from, right? So, and people will say this, they'll say nothing feels as good as the first time, right? So we feel that, right? We actually feel that subjectively. And at the same time, our fear systems, that's sort of like our extended our habenula, it gets more and more pronounced because what's happening there is the brain is trying to balance itself out. So we're flooding it with the good feelings. It's just trying to be level, right? So the fear circuitry actually gets more and more pronounced. And that happens as well. People feel that as well. Hangovers and withdrawal get worse. The deeper into your addiction, the worse your feelings of come down are. This again correlates to how people feel. And so over time, it's less and less about having a good time. It's more and more about having a bad time. And they've actually demonstrated this in some really interesting ways. So they took a bunch of people who were addicted to cocaine and they put them in a brain scan, a functional MRI, and they showed them powdered methylphenidate, so stimulant, Ritalin. And they just looking at it, their reward center went haywire. It was like, boom, cocaine, I love cocaine, give me cocaine. They then gave them the powdered methylphenidate and the reward center was completely uninterested because it had nothing to learn from the millionth hit. They did it the same thing to people that were naive to cocaine and they looked at it and their reward center was completely uninterested. It doesn't know what stimulants are. It wasn't interested at all. But then they had the methylphenidate and their reward system went haywire. I was like, oh my goodness, first hit of this, this really reinforcing drug. So that's what happens to us over time is that we get these anticipatory dopamine releases, right? So there's this big rush, this big craving rush. And again, people will say this. People will say, often I've talked to people that are stimulant addictions and they'll say to me, it feels like I'm on before I'm on. Or they'll say they'll text their dealer and that's when they get that rush they need to go poo. Not when they've used, but when they've gotten that, because that's when they're getting that huge noradrenaline dopamine rush, right? But then when it's actually used, genuinely, if you can catch someone just after they've used in the depth of an addiction, they'll tell you it's not that good. Like, I'm not feeling the joy from this anymore. I used to many time ago, and that's what I'm chasing, but my brain is not giving me that. And then the other change that happens is that our sort of, our prefrontal cortex, the sort of front third of our brain, which is doing a lot of the advanced thinking, and keyly a lot of the inhibition, a lot of like, I'm not going to do that now, I'm going to do it later. It gets less able to resist those sort of strong push cravings, and we lose the ability to inhibit that. So that's on a neurological level what we think is going on, and I like it because it does really correlate to a lot of things. That often when I talk to people about that, they said that's exactly how I feel. Like that really correlates to what it's like. So I really like that as an explanation. I really recommend George Cooper. I think he writes excellently.
That is absolutely perfect, man. So just two things off the back of that, right? Number one, I love a study where they put two people in the same situation. It's just the amount of information that comes out of them is absolutely nuts. Like, I believe there was a study where they put a rat in a tub of water and it couldn't swim, and the rat very quickly was going to drown. Took that same rat out of the water and then gave it a break for a little bit, put it back in. The rat swims for crazy. It's like something like 22 to 24 hours. Like, it's just the way the brain works. And then, so I feel like studies like that with drugs can really, really help us as humans understand why we do what we do. Because the second thing that you said there that I could really relate to and sort of fired me up a little bit was when I used to buy needles in the fit packs when I was heavily using, the smell of the swabs that used to come with the needle pack, it used to make me and my friends dry reach. So we would be literally preparing ourselves to do what we were addicted to do. And as soon as we got on, it was shit. It was terrible. But that whole lead up and the build up of actually opening all those packets and getting everything ready and smelling those smells, that was more exciting than actually getting on the drugs. So once we figured that out for ourselves, a lot of us started realizing that it wasn't just about the needle and the intravenous using and etc. It was about the whole process of, mixing it with water and then preparing it and then getting it all ready and da-da-da. And then sometimes on certain days we'd find ourselves procrastinating through those stages because that was the only bit that we were actually getting enjoyment out of after 9 or 10 years of using. It's fucking crazy.
Yeah, absolutely. So two things, right? So the rat test that you're talking about, that's called a forced swim test, where essentially you put a rat, we're bloody cruel to rats. Like it's awful when you hear about what we do to rats, but you put them in a tank and they can't get out. And then you measure how long it takes them to swim, and eventually they'll just stop. They'll give up. And you can do all these things, give them a break or give them a certain medication. And it's a model for depression, right? It's called learned helplessness. Like if I put you in a room with no door and I'm just like, walk through the wall, you'll do it because you want to get out, but eventually you'll internalize that and you'll get depressed. You'll say, I'm not going to try anymore. And that's what we're doing to these poor rats. And why I think learned helplessness is so important to talk about in addiction is learned helplessness, right? When we're in addiction, we don't want to be in an addiction, right? We're trying and trying and trying to get out. And eventually we internalize a no-win situation as it's our fault. And then we stop trying as much. So a lot of what I do in my job is helping people get that sense of self-efficacy back, get that self-belief back. Because if we don't believe that we're going to recover, we're fucked. So to me, it's really, really about even if it's that, as you say, you get a bit of a break and then you can continue the fight. And that's so important. Sometimes we need a break. Sometimes when we're struggling, people just need I was saying, mate, actually what you need is to take a week off work, eat healthy, meditate, go to the gym, and you'll feel much better. The other thing that you were talking about, the cue related cravings that you and your friends are experiencing, and that linking, you're getting all the feelings, you're getting all the reward system firing up when you get that. And I guess that's what happens is then the brain's trying to associate things with the drug, because remember, the reward system's all about learning. So it's trying to learn the cues with it. And that's where we're getting those reward things. So the more cues we can associate, the more learning, the more we can get that reward. And there's really, really well evidence in terms of when we talk about what triggers cravings. If you think about it, if I have an alcohol addiction, in Australian society, I'm constantly exposed to alcohol. I can't go anywhere with it. But most people say I actually don't feel that level of cravings from that. But if it's a very specific thing, like let's say I always drink in my bedroom, I can feel overwhelming craving going into the bedroom, because that's where our brain has done that associating, and we're getting all that sort of sort of anticipatory dopamine release. So it's really, really important to identify what it is in our own personal life. What is specific to our own addiction, and so we can focus in on that. Because as I was saying before, it's not about having willpower. It's about saying, all right, well, I'm going to, if it's my bedroom, I'm going to move bedroom, or I'm going to move it around so it doesn't look the same. So I'm going to trick the brain into not firing off, because we're trying to create a life where we're not, because we've lost that control. It's one of my favorite quotes I stole from an Instagram sobriety influencer, where he said, I'm 10 years sober, and people always say to me, you must have a great willpower. And he's like, I don't have any willpower. I'm an addiction. I've designed my life so I don't need it. That's it. And I thought that was terrific. And that to me is what it's about. It's about trying to find this way where we're not putting ourselves at risk. We're not in willpower. We don't need willpower. We've designed a life that is not conducive to substance use.
Yeah, man, 100%. That's really, really, really good information for people as well. Like, it's something small and little that you can take. And it doesn't have to be this massive, like, you like you're saying with the bedroom, you don't have to go into your bedroom and paint your whole fucking walls a different color. Just move shit around, man. Make it look different. If you're coming home from work and you're going and sitting in your shed and there's a fridge in your shed and you're knocking off 6 or 7 beers, don't sit in your shed after work, man. Go sit in your lounge room. Do you know what I mean? Like, it might be boring, but last week's podcast that I did, I shared some of the stuff that I used to recover, and I referenced it as shedding your skin like you're a snake. And I feel like we can relate that into what you just said, because if you don't shed your skin, so to speak, and you just keep being a creature of habit, going back to this same thing, you're going to get the same result moving forward.
Sorry, Gary, my kids were just, dads on the can't help themselves. Yeah. Sorry, that's buggered that. Sorry.
No, that's all right, man.
Yeah, I mean, that's it. It's little things, and it's just trying to disassociate. It's just what I do. A lot of people are saying about the shed. A lot of people say, because often people will say they sit in their car, and it's that you get home from work, and especially as we were talking about being dads earlier, it's like another shift as soon as you get home, right? So it's like, why not chuck a little 20-minute break, or do a 10-minute meditation, or go for a walk around the block. Give yourself that disconnection where you do just have a little bit of mental space. As you say, it's just that little stuff, right?
100%, man, 100%. So what actually changes in the brain after long-term drug and alcohol use? Because I know that for myself personally, it did take me about 2 to 3 years to actually come back to being able to get my full sort of brain function. Can you tell us about that, please?
Yeah. So there was those changes I was saying. So the fear circuitry gets more pronounced. Reward circuitry is less pronounced about certain things, and the sort of cravings and inhibition circuitries is working probably less well around several things. So this one, so what then we get is from this is this concept called it's called hyperkatifia, which means mega pain. So it's essentially because our fear circuitry is so fired up, we actually experience more emotional distress all the time. So that's why people in an addiction are actually much more likely to develop an anxiety disorder, to develop a depressive disorder. We know that they are already more likely to have one, to go and develop an addiction, but having an addiction is much more likely to result in one because we experience more negative emotional content. So that certainly happens, and that will certainly reset, right? Over time, the brain is always changing, and over time that'll change. A lot of this would come down to the drug itself. So if you're on alcohol, can cause some, and I guess it's also about a lot of things. When we're in an addiction, we have nutritional difficulties. So people can have difficulties with vitamin deficiencies that aren't actually sort of secondary to the substance, but occur because we're living in an addiction. We're not looking after ourselves, So people can get a thing called Korsakoff psychosis, which is from not enough vitamin B1. Nitrous oxide can cause us to have B12 deficiency, and that can end up with some pretty permanent and horrific brain damage. Alcohol can cause alcohol-related brain injury, which also can be pretty permanent. Any sedative can, we can end up with hypoxic brain injuries because of, opioid or GHB or anything that sedative causes us to just not breathe enough. So we get a hypoxic brain injury, we're not breathing enough. But most of the stuff, most of the drugs, stimulants in general, there's not really any long-term brain damage we think will necessarily come about. It takes a while for all that circuitry to reset, for us to be able to reset our sort of happiness thing. Oh, the one thing I should also mention is benzodiazepines, right? They can cause this thing called benzodiazepine-induced neurological disorder. But the thing about that is it's not permanent. There's no evidence to think it. So people often say, I can't think at all. I feel like I'm foggy. I'm forgetting things all the time. It can persist for a couple of years after you stop benzos completely. But after that, you should reset to normal. So exactly as you were saying, Gary, I think a lot of this stuff is, and it's hard to disentangle the effect of the drug from the effect of the lifestyle that goes with the drug. But we do get, our brain should reset. That fear circuitry should calm down. We should be able to get more enjoyment out of normal things. But unfortunately, we can come out of it with some deficits. And that's why it's really important to, make sure that you're seeing a doctor and make sure that you're doing all the healthy things, even when you're not in recovery. Even when you're thinking about recovery, there are things we can be doing when we're using to massively mitigate the risks of us getting any sort of permanent injury. So we could be taking vitamin supplementation. And even if we're thinking, I'm not ready to stop, well, then let's have an eye down the road, because in the future we could be, and let's be doing this safely. It's stuff like using sterile needles, right? Is harm minimization stuff that we can be doing to make sure that we come out of it all healthy and alive.
I think that's really good. Really good for people to hear you say that as well, because I just want to let everybody know that is listening. You are not broken. This isn't going to be you for the rest of your life. You will recover. Your brain will come back from it. These foggy days that Richard was just talking about, it is a part of the recovery that you do have to go through. And I guess an easy way to put it would kind of be like when you're on a boat and it's foggy and you can't see, but then you eventually do sail through the fog out into the clear. You can see and think clearly again. So you mentioned dopamine before, and I do want to speak to you a bit about that, because I know that it does play a massive part in why people choose to use and why they relapse again. Like when you were saying before about maybe people not being happy with the way things are feeling when they're in the first couple of weeks of recovery and they're feeling quite down
Mm.
and things aren't going too well. So what role does dopamine play in all this?
Yeah. And I think it's a popular hormone, right, and a neurotransmitter right now, right? There's some great books. It's a book called Dopamine Nation by an American psychiatrist called Anna Lemke. The Dopamine Brain's another good. So look, and I guess I worry a little bit when we talk about dopamine that it's become a bit, the same way that we can get this concept of the magical drug, right, where we can say like, oh, it's just all the drug and it's not about the wider psychological issues or the problems with society that's causing addiction. It's just, the evil drug. And I'm like, well, I actually think, it's emerging as a result of quite a lot of complicated things.
Yeah.
I worry we're doing the same thing with dopamine, right? It's becoming the magical neurotransmitter. Dopamine does a lot of things, right? It does. People with Parkinson's disease don't have enough dopamine, so it regulates the way we move. And people with psychosis have too much dopamine because there are sort of four main dopaminergic paths in the brain. One of them regulates whether we lactate or not. So if you don't have enough dopamine, you'll lactate, in a certain path, right? And so that's probably got nothing to do with addiction, I think we can say pretty comfortably. One of them's about sort of thinking. One of them's, as I said, about movement. One of them's about sort of reward stuff. And that's where we think the role of dopamine in there. It regulates a lot of how we learn and reward learning. And that's really associated with addiction. Because if you think about it, addiction is as I was saying, it starts off being all about the incentive we get from using something to have like the reward circuitry, and then it ends up being more about I feel like less about dopamine and more about the fear circuitry and about activity in the fear circuitry, which is probably glutamate mediated rather than dopamine. But to me, the start of it is about dopamine, and the end of it is about this increased negative feelings we get about it. But I mean, there are also obviously lots of drugs of abuse that directly impact dopamine, right? Like stimulants and cocaine, they are directly dopaminergic drugs. So they are just even more into the dopamine circuitry than the other ones. But that doesn't mean, opioids are very, very addictive and they don't have a direct dopamine activity at all. It's indirect. It's the reward learning about opioids. So dopamine is important, especially early on in our addiction, but it's another neurotransmitter. And I think when we focus on recovery, we should be focusing on connection, finding a life that is conducive to happiness and that sort of stuff.
I think with social media as well, there's a lot of I wouldn't say misinformation flying around a lot, because some of the influencers and some of the other recovery podcasts and the social media people that do videos, there is a lot of help out there for people, you know.
Big time.
But I think maybe with some of the articles on the internet and some of the misinformation that can fly around, I think it's very distracting for people as well. You know, if you read a few of the wrong things, it could send you down a bad path.
Well, I think it's, as we were saying before, Gary, it's like, it's the most complicated thing in the universe, the brain. So, it's like, of course we simplify, even that book that I was saying, Dopamine Nation by Anna Lemke, which is a great book, and she's obviously very clever, but she says in the middle of it, she says that, what she tells her patients is, stop using whatever drug. And if you come back in a month and you're still miserable, it wasn't the addiction that was making you miserable, and there's something else. And I was like, what? Like, what are you, what are you talking about? Like, that's so overly simplified. And like, things are like, annoying. Yeah. So, I mean, I don't think it's just social media. I think it's so complicated. And that we're always going to get things slightly wrong. And I think when, when we were talking about, when people with disease model, what I actually think that argument is about responsibility. I think when people talk about dopamine, what they're really saying is just like, there's a part of our brain that we can't control our use, and we're using dopamine as a neurotransmitter, as a stand-in there for like just this. It's not like, I think what we're trying to communicate is, it's not, people in addiction they don't want to be in an addiction. They're not somehow weak-willed or soft, or, it's just, it's a brain illness that is occurring. And I think that's, and if that's how we're using it, then, I don't know. I don't know what, who knows how the brain works. So maybe I'm completely wrong and it's completely dopamine. I don't know.
No, it's still, man. I mean, I think with people doing work like what you're doing and what you explained to us that you have done in the past, I think there needs to be more people like you who are looking this deeply into these sort of topics. And that's the reason why I got you to come on the podcast today, was because me being a recovered addict myself, some of the shit that I went through to get clean, I now see other people getting help that wasn't available to me, sort of 7, 8 years ago. And I do really wish for people to take that help and use it for the most positive way in their life. Like if you can listen to a podcast of a person who has recovered and they share their story, then fucking do it. You know what I mean? Because when I got clean, I just remember sitting in a room nearly feeling dead. Like I felt so empty. Do you know what I mean? And I'm just lucky that I've got my beautiful partner that I do, because she always had this positive outlook on what was actually happening when I just couldn't see that. The brain must be one of the hardest things to actually study and get some true actual statistics about, because everybody does recover differently, don't they?
Yeah, 100%. And we're also independent. And I think, when you say what's available now that what wasn't available back in the days, is the peer stuff and the group, the podcasts and all that stuff, and I think my path to recovery is what I'm always saying to people is, everyone needs a sponsor, everyone needs a group, and also everyone needs medical advice. And I think also everyone needs psychological advice. Like, I think that and what I've seen come along, I'd say in the last 10 years, is just the increasing acknowledgement and importance of the value in peer recovery, in the recovery process, right? That's what I think. I don't want to speak for you, Gary, but I mean, surely a podcast like this, where there's hope and you can hear people that have gone through the same thing, is so important. And as you say, it's nice to know the sort of more textbook stuff and about how the brain works, but surely it's much more valuable to hear from someone that's been there and see the people in longer term recovery, and see that their lives are improving, and see that that's a path that's ahead of you.
100%, man. Like I'm also at the moment writing articles for a prison newspaper. So it is about some experiences that I had when I was first in prison, some of the stuff that caught me off guard. I'm writing a third one at the moment about transitioning into normal society and how important a job's going to be. And it's crazy now, like actually inside of prisons where people are going because of their addiction. So if we can link this all into a sort of a big full spec picture, they have access to tablets and the internet inside prisons now in Australia. So once again, before, when I was in jail, which was for like 2015, 2016. We literally just got sentenced and sent away, and fucking the boys were just using a shitload of subbies in there anyway. Do you know what I mean? It's not like I got away
Mm,
from drugs in prison. There's
mm.
more drugs inside jail than there is out. It's a fucking crazy, crazy thing. And so the reason why I jumped on that program and started writing these articles was I remember thinking to myself, how fucking cool would that have been? Instead of going out to the oval and just walking laps of the oval and dribbling shit with everyone else who's not fucking going to make a change like the reality of it is in Australia. I think the statistic is like 40% of people in Western Australia, in the Western Australian system, are just on remand. They're not charged. They're just sitting in jail waiting to see court. So for me, I went, how good would that be for myself if back then I could have gone into the library and, taken one of these iPads and gone sat down in a corner and just got 10 to 15 minutes of just real information, that lived experience from someone. So I feel like our society is moving forward in a positive way like that. And I think people need to take advantage of that.
Yeah, big time. Big time. That's really great.
Thank you for that, man. It's definitely been a bit of a pinch me moment, I suppose, doing the podcast
Yeah.
and then writing these articles and stuff. It's sort of like, holy shit, man, how did how did this all happen so quickly?
That's
But
terrific.
thank you. I just wanted to get into some of the ADHD questions as well, because me personally, I do have ADHD, and I know that a lot of my friends do, and a lot of people listening could have, like, their kids had
Yeah.
a reference from the school or something like that. So please correct me if I'm wrong here, but I believe the rise in ADHD diagnosis has risen 300% in 10 years. So could you tell us about that, please?
Yeah. It's about, I couldn't without, I'm going to trust you, Gary. I couldn't without reading the stats in front of me. I couldn't confidently quote them. But that sounds about right. It's, and why, this is why I got on Sunrise, because I have a real problem with the way its current system works. Right. So it's basically, it's something that the public system doesn't address really. It does in kids, but in adults, certainly not. And so it's been taken on by the private system. And a lot of that is telehealth people, where you're seeing a psychiatrist paying thousands of dollars for an assessment, which is also the idea of, to me as a psychiatrist, if I'm working privately, I'm charging for my time. I'm not charging for a diagnosis. And I find that very confusing. If you're charging, also thousands of dollars is way more money than you should ever be paying a psychiatrist. And my thoughts are, one of them is, if someone will sometimes come to me and they'll say, I'm worried I have ADHD, and I'll talk to them, and it's quite obvious that they're, currently suffering from schizophrenia or OCD. And if I'm charging them, like $5,000, what do I stop halfway through my assessment and go, I'm going to give you $4,500 back because you have schizophrenia? Like, it doesn't make sense to me. The concept of the way it works is very troubling. And I think what's motivating that is not a, I think what possibly some of the motivation there is not a desire to help patients, but rather a desire to make money from sort of corporations. And so that's what I was writing about there. And I was also writing about the fact that if we think about what are the symptoms of ADHD, well, you're more likely to not finish school, you're more likely to struggle to hold down a job, you're more likely to use drugs, you're more likely to end up in prison. That's a group of people that are less likely to be able to afford the $5,000 telehealth assessment, all the complicated, like, paperwork and wait list and all this to get to that, right? So why have we designed a system where there are people that are in need of treatment we're just making it inaccessible to them? And what we are making it accessible at the same time, we're making it accessible for perhaps people that have a much milder end of the spectrum that perhaps don't need the treatment as badly, are much more able to get it. So I guess that's my problem with the current system. So we wrote an article essentially saying, well, this is really worrying. The rise in ADHD is, so there's increased awareness, personal opinion. So there's very good evidence that, as you were talking about, social media, and there's evidence out there that when they look at social media influences about ADHD, a lot of what they're attributing as symptoms of ADHD wouldn't be considered symptoms of ADHD according to the American the DSM. So it's like, is this ADHD? I hesitate to use the words misinformation. I think the definitions of diagnoses change over time, but let's say according to sort of the current definition, that they're not symptoms of ADHD. And often people do, as I said, come to me and describe symptoms that are not conducive to ADHD, are conducive to another illness. And when we treat that, they get a lot better. So there's that. I think then, I'd never watched Sunrise before. when I was there, I think like it was nuts. I don't know if you've ever watched it, but there's a new segment like every 15 seconds. And I was thinking, shit, no wonder the world's getting more ADHD. This is nuts. This is sunrise. This isn't even like reels, where people when you're watching sort of reels on Instagram or TikTok and it's like, and I'm like, I think there's a lot to the world where, we're expected to be like, people will grind set and study for hours on end, but at the same time, your phone's giving you a million notifications at once. And, so that's certainly something that's been written about is that, the modern society is really not conducive to having a good attention span, yet it's demanding one of us. And then there are all these other things. So there's evidence out there that hyper-processed foods are affecting our concentration. So there's I think that it's like, it's incredibly complicated. I think there are lots of reasons. There's the under-recognized condition getting more recognized. There is a world that is less and less conducive to having a good concentration span, but more and more demanding of it. So there's probably a misinformation about, there's a poor idea about what exactly are symptoms of ADHD or whether symptoms of other conditions. I think there's lots and lots. And I guess, what I was writing about was just how I think that, call me crazy, Gary, but I think that medicine should be designed to help people most in need and not to make profit for people that have medical degrees. So that was really my problem with the current system.
Thank you so much for the work you're doing around that, because I do share the same opinion. And I guess in the school system as well, if we could just talk off the back of what you just said, it's happened with my daughter. I think like the schools and stuff are very quick to put forward, I think you should get your son checked for this. I don't want to call anyone out or say any specifics here, but I feel like the teacher who's in the classroom with, say, 15 to 20 students, and boys being little boys, man, do you know what I mean? Like, not every little boy is going to sit still on the rug for fucking story time every single day, do you know what I mean? They're going to get distracted. They're going to run around. And I feel like kids are being sort of ushered in this way towards go and get him checked or go and have a look. And off the back of what you just said, there's a sort of a lucrative business on the other side of it too for these people who are prescribing this medication and doing this sort of stuff as well. So it's kind of like this leaves a bad feeling in your mouth sort of thing.
I couldn't agree more. Look, I think in the past what we were doing, we were under-recognizing it. And I think we're probably more on the skew of over-recognizing in some people, over-recognizing in some people, and probably still under-recognizing in other people. Like, so it is so hard, as I'm sure it is so hard if you have a forensic history or an addiction history. I have other psychiatrists refer people who have quite clearly got quite significant ADHD and lives would be very much improved, but they're like, oh, he's got a history of addiction to ice. I need him to see an addiction psychiatrist before I do anything about this. I'm like, well, these are the people we need. Like, these are the people who need us most. Like, this is who we should be. So I think that, but I do. Yeah, there's a wonder. So right now, the push in all. And I'm not a child psychiatrist, so I don't want to get to it, but there's a push in all sort of child health is that early diagnosis and early intervention is what we need. But there's actually very little evidence for the benefit of that. And I wonder if I worry about the message we are sending to a young child. As you say, boys run around and it can cause a mark, and are we preventing them from learning how to, by helping them with an external substance to concentrate, are we preventing them from learning how to learn those skills from themselves? All boys are chaotic at one stage, and by giving someone a label and some sort of an external thing and teaching them they're different, pointing out their differences, we may be saying that's fine because you can do great and no worries, or we may be saying you are different and they'll achieve less recovery than they could. And it's a tricky. So a good analogy is if I had some sort of muscular disorder where I just couldn't grow muscles, you would give me anabolic steroids, right? Because I'd need to and if I'm a kid, I would get testosterone, I'd get bigger, and I'd be normal, right? But if I was just really weedy, you'd be like, no, you just need to go to the gym more. And there's some line in between there where my muscles get small enough that you think it's appropriate to give me steroids, right? And that's really easy for us to understand, right? There would be a blurred middle ground, but we'd all agree that we shouldn't just give skinny kids steroids, and we should give kids with muscular problems steroids, right? If you need that helping hand, then we should be giving you that helping hand. But if you don't need that helping hand and you can get that from within, we shouldn't be, because our intervention can be harmful. And that's where I worry about is like, what kid are we saying to kids? You're different, or you're preventing them from learning these skills themselves. And I think for some of them we probably are, but for others, they need that helping hand, and that's great. And it's great that we can give them. So and so much of it comes down to philosophy. As an addiction psychiatrist and as someone in recovery, I'm sure you and I have more hesitation about substances of any kind, right? I want a life less medicated, where other people that have had really enriching experiences from medication might have the complete opposite attitude, right? So I think we got to be aware of our own biases as well.
Yeah, nice. Yeah, that's a pretty fair way to end that conversation, man. Like, I suppose on your life experience as humans, we definitely do go with what we've learned in the past and what's worked for us, and I suppose that is another dangerous element about medication too, is if it's worked for you before, you're more likely to, I don't know, maybe suggest it to someone that you don't know their history, and that could be the complete worst thing for them.
Yeah. That's I love peer support stuff, but that's my one thing is when someone's like, oh, my sponsor told me to go off my antipsychotic, and I'm like, mate, you just need to get a better sponsor. Like,
Is there a strong link between ADHD and addiction, do you reckon? Do you reckon that's a
big
fair
time.
thing?
No, that's beyond doubt. Yeah, really evidenced. I can't remember off the top of my head, but it's like, some estimates is like 30% of people with an addiction have ADHD or something. It's very, very high.
Yeah.
There's a real link. There's a definite link. And if you think about that, impulsivity, right? That's key part of ADHD is impulsivity, right? And impulsivity is why we start it, why we try a drug. And if we're trying a drug, we're more likely to get addicted. Then we can also think about it like, ADHD is more likely to end up hold down a job, relationship problems, behavioral problems. These are things that make our life worse. And as we're talking about, the worse our life is, the more likely we are to engage in an addiction, right? It's that negative reinforcement, that using to not have a bad time. So I think it's beyond reasonable doubt that ADHD and addiction are definitely linked, 100%. And these are the people that need to be getting treated for ADHD. That's one of my frustrated with the system, where people are hesitating and treating someone with a history of addiction for ADHD. I'm like, this is, that's where ADHD's got, like, when we talk about evidence of, greatly increasing people's quality of life, it's reducing likelihood of having an addiction and stuff. So people with an addiction, ADHD, that we should be targeting them for treatment. We should be designing systems that are easier and easier to get treatment for ADHD if you have an addiction.
Yeah, I guess with what you were saying before and the statistic I threw out there, which I hope is correct, but I'm sure there will be rise in that in the future. Like, there's got to be some sort of study that comes out previous, like, sort of moving forward, that says like, all right, this group of people are more prone to this. Like, we need to hone in and focus on them rather than giving them the same treatment as the bigger picture, because it's just clearly not working.
So there's lots of studies that definitely say that addiction and ADHD are linked, and that treating ADHD in people with addiction is linked to better outcomes in terms of recovery. It's lots there. It's just the current system is just not designed to help those most in need.
And I mean, it's brutal, but I suppose it's the one that we live in, and I suppose you sort of have to take what you can from it and move forward with it. So how can someone tell if their addictive behaviors are linked to ADHD, or there is that blend of confusion before? I know it's probably a hard question to answer, but
yeah, it's so hard. It's so hard. I think that's really one that you've got to look. The first thing is you need to rack up a bit of abstinence. There's no real path to getting your ADHD treated without recovery. So that would be your first step. Getting 2 to 3 months abstinence. And we were talking about how brain resets and recovers in the months post recovery. And so there are a lot of people, especially stuff like cannabis or benzos, that really affect cognition. People come to me and it's like, I can't think, you're getting brain fog, my memory's shot, I think I have ADHD. And it's like, well, let's find out. And a lot of people get a couple of months of sobriety and like, oh no, it's I can already feel that stuff getting better, and it's going to continue to get better. And I guess the other thing with ADHD that's really clear is that symptoms have to emerge before the age of 11. So it's a developmental condition. So you have to have, so it's very clear. So sometimes people will say to me, I've noticed in recent years, my memory's really bad, my concentration's really bad, and it really correlates really well to when their addiction's getting quite bad or their other stuff in their life. But you look back through their school reports and it's very clear they any sort
Yeah,
of
okay.
difficulties with cognition back then. So there's stuff like that. But I think it's really personal, and it's best done talking to a doctor that you trust and wants to help.
Yeah, man. Nice work. Great. I've actually been really impressed with the answers that you've been given and the way you've spoken today. It's been really, really helpful, even just for me to hear what you're saying as well. And I feel like people will be able to take, not just the snippets that I put up on social media about this, but, maybe you might find somebody listening to this podcast 2 or 3 times over or suggesting it to a friend, which is like, massive, massive in our society, like we were saying before. But so, can you give any advice just before we close up the interview about some habits that people might be able to build in their early years of sobriety or battling with ADHD that's easy just to help them?
Yeah, absolutely. And likewise, Gary, I've had a lovely chat, mate. Thanks for having me on. Um, so to me, a healthy, happy life, no matter what, has got structure, it's got routine, it's got plenty of exercise, it's got a good sleep pattern, and it's got a healthy diet, and it's got some form of meditation. And this we can take this across all mental illness, or even if we don't, this is a mental health concept. So, so if we're going to go to ADHD, people are very quick right now to jump to pharmacological solutions. I'm not in my office right now, but I live my life through to-do notes. I've got an A4 piece of paper with little task and a box next to it, and I cross it off as I go. And that's how I live my life. So that's non-pharmacological management of ADHD. I mean, not that I have ADHD, but that's just it's a handy structural tip. And if you see an ADHD coach, that's the sort of tips they're going to give you. And it's, so there are things we can do to help our life in terms of that sort of, I also live my life off my phone calendar. It's got reminders, tells me where to go, what to do. It's even got stuff like if I know I have a uni assignment I'll plan ahead and I'll put in slots, 2 hours study every weekend. And I've got that put on my calendar, and I know I've got that time devoted coming up. So there are things we can do to add structure to our life. In early recovery, to me, I really am a huge 12-step fan. I think that we need to be finding a meeting that suits you. If, people often tell me, I didn't like it, but I'm like, that's just one meeting. Like if I went to a footy club and everyone in that footy club was weird, and I walked out and I said, "Oh, AFL's weird." That's the wrong take. That's just a weird club. You know what I mean? Like we said, and that's my thing is go to a lot of meetings. Try it because, a meeting's
Yeah.
only as good as the people that go to it. And I should really try the different groups and the different meetings. I really am a huge 12-step fan. And I think it should be part of everyone's recovery. A peer support group of some sort is definitely, so if you don't like 12 steps, Smart Recovery, there are lots of different ones. And I had a rabbi on my podcast who runs Jews in Recovery the other day. I had a priest and an Islamic scholar. They had, their own specific 12-step like programs that were not officially 12-step affiliated. But I think, that sort of connection is so important. I think exercise has got, it's the evidence for the best antidepressant ever made. It's the evidence for the best anti-anxiety medication ever made. It's got benefits on sleep, on concentration. So we need to be devoting time in our life to exercise. Meditation, 5 minutes in the morning can change your life. And people, I think, think, oh, meditation's hippy-dippy. It's one of the most evidence-based things we can do to help our mental health. So I'm a big fan of it. Making sure that we treat our sleep with respect and we give it the time it deserves, and we take it seriously and get our sleep hygiene right is also so important. Basic things like that make our life worth living.
So thank you so much for coming on today. That's a beautiful way to end it. I think we'll just end the chat with that nice, easy, flowing information for people to be able to take what you've just said and incorporate it into their own life and their own sort of universe that we all live in, our own little world. And, I've really, really appreciated you coming on. And I feel like the chat that we've had today has been massive. And you are actually the first doctor that's come on the podcast. So there you go. Thanks for that, man.
An honor. Thanks so much, Gary.
That's all right, man. Well, I have 2 kids' birthday parties to go to today, so I am going to be a very busy man for the rest of the day, man. So I do need to go. And for everybody that is listening, thank you so much for supporting me. And that's right. Just quickly before we go, how do people find you, man? Where do they find your podcast and how do they get you on social media?
Yeah, so we've got substance stories. I don't know. I thought you can collab on. Sorry, I'm bloody
Yeah,
useless. I've got the Instagram.
yeah.
My friend who does this stuff, he's begging me to let him do it, but
I got your back,
I'm not
bro.
on the
I got your
TikToks.
back.
So, but we're on all the podcast things. And I've got if you live in Victoria, there's absolutely work out of the Victoria Clinic. There's a website, drbradlow.com. But even if there's great. The thing about addiction help is there's actually so much out there that's, I think, pretty poorly communicated. Like if you live in Victoria, call Direct Line. It's a 24/7 helpline. It's free. It can hook you up with treatment of all sorts, whether that be medical reviews, free drug and alcohol counselling, inpatient detoxes. There's lots of resources out there. I think it's not communicated enough.
All right. Once again, Doctor, thank you so much, man. I'll let you get back to your day. And for everybody
Nice.
listening, we'll be back next week with episode number 33. Thank you.
Thanks so much, Gary.